Welcome everyone to the session 2 of the Asia-Pacific HIV Clinical Forum 2020. The title of this session is The Clinical Aspects of the Implementation of PrEP. My name is Nittaya Phanuphak, and I'm the Executive Director of the Institute of HIV Research and Innovation, or IHRI, based in Bangkok, Thailand. Today we have 3 speakers in this session: Professor Molina, Dr. Azwa, and Dr. Koo. Now let's welcome our first speaker, Professor Jean-Michel Molina. Professor Molina is Professor of Infectious Diseases at the University of Paris and head of the Infectious Diseases Department at the St. Louis Hospital in Paris. He is involved in the French National Agency for AIDS Research, or ANRS, where he chaired the clinical trial group for the last 12 years before becoming a member of the ANRS Strategic Committee. His field of interest from treatment of opportunistic infections to treatment of HIV, and now to prevention of HIV using antiretrovirals. He has led the ANRS iPrEP trial in MSM, and most recently, the ANRS PrEP study among gay men. The title of his talk is Implementation of PrEP, Efficacy and Resistance Considerations.
Thank you very much for this kind introduction. It's a pleasure to be here today. These are my disclosures. Let's start with the global picture of the HIV epidemic today. And these are data presented during the IS conference in 2020, earlier this year, from UNAIDS and WHO. And as you can see, in 2019, there were 38 million of people living with HIV. And in 2019, there were 1.7 million of people newly infected with HIV. The good news, though, is that the number of new infections in 2019 has declined by 23% as compared to 2010. And also the number of deaths has decreased by 39% relative to 2010. However, the bad news is that among the new HIV diagnosed in Asia, 30% were reported among MSM and transgender women, which are disproportionately affected by this HIV epidemic. So we need to do more in terms of HIV prevention in these high-risk individuals. As you know, we have a number of tools to prevent HIV infection, and among those tools, we have pre-exposure prophylaxis, or PrEP. And PrEP has been advocated since 2015 by WHO as an additional prevention choice for people at substantial risk for HIV infection. And by substantial risk, WHO means people with, or population with an incidence of HIV greater than 3 per 100 person years of follow-up. And clearly, in many parts of the world, men who have met sex with men and transgender women have an incidence of HIV greater than these 3 per 100 person years. Let's look now at the global map of PrEP implementation in April of 2020. And this is a slide from the AVAC website. And as you can see, in terms of the number of new PrEP initiations, you can see that PrEP has been quite widely implemented in North America, in Brazil, in Latin America, in some countries in Europe, in East and South Africa. And if we looked at Asia, it's mainly Australia, Thailand, Vietnam to a lower extent, and also Taiwan, where PrEP has been implemented. But again, there is a long way to go until PrEP implementation is at the level we could expect to have a strong impact on the HIV epidemic. So the issue is, how do we do now to upscale PrEP implementation, since we know PrEP has a high effectiveness in preventing HIV? The first issue is clearly to increase awareness among people at risk of HIV acquisition that there is a new tool which is very effective. And to do that, we need to partner with NGOs, with government bodies, to really implement awareness campaign and advertising campaign. We clearly also need to integrate PrEP with other healthcare services. We need to increase the number of sites delivering PrEP and involve also general practitioners to develop and to propose PrEP, because prescribing PrEP should be part of a global sexual health care. We clearly need also to address the concerns that some physician or government may have in terms of increasing STIs or cost of PrEP. And I think it's important also to expand PrEP beyond MSM to other high-risk groups so that PrEP is not only a pill for gay men. And finally, we need to measure the impact of PrEP implementation on the HIV epidemic country by country. And this is, for example, an advertising campaign for PrEP in France, in the Parisian metro in 2018, where you see these large posters, which have had an impact in terms of awareness and people willing to get access to PrEP. Of course, PrEP should not be used alone, and it's a combination of tools that may have an impact on the HIV epidemic. And if we look at the data from England, and this is a public health report from 2019 in the UK, you can see that in a country where HIV testing and immediate treatment have been implemented for already some years, following the beginning of PrEP implementation in 2015, you can see that among gay men in red, there was a significant decline in the number of new HIV diagnoses in 2018. So only 3 years later, there was a nearly 35% reduction in the number of new HIV diagnoses among gay men. This was not seen in the other population with limited access to PrEP. So what are the PrEP regimens which are available today? We have a number of options, and that's great that people can choose between these different options. We have the oral pill with TDF-FTC. We have more recently data with the oral pill of TAF and FTC, and this combination has been approved in the US for PrEP. The dapivirine vaginal ring for women has got a positive review at EMA, which is the first step to implementation in Africa for women. So this is going to be a new option for women in the near future. And more recently at the IS conference a couple of months ago, the HPTN 083 trial demonstrated the efficacy of cabotegravir long-acting intramuscular injections for MSM and transgender women to prevent the HIV acquisition. We also have a number of investigational agents that could be used in the future to expand PrEP options. We have neutralizing antibodies. We have long-acting oral or parenteral agents such as islatravir or lenacapavir. And we hope that not too long, we will have implants which could be used once a year or every 6 months with islatravir and TAF. And this is a work in progress, but quite exciting. Let's focus our talk now on MSM and transgender women and review the data suggesting that PrEP is quite effective in preventing HIV acquisition. And the first data of PrEP effectiveness among gay men and transgender women come from the seminal study conducted by Bob Grant and colleagues, the IPREX trial, where quite a few individuals were actually enrolled in Thailand. And in this trial of nearly 2,500 people, MSM and transgender women, they were randomized to receive either a daily pill of TDF and FTC or a daily pill of placebo. And as you can see on this graph, after a median follow-up of 14 months, 64 patients in the placebo arm in red became infected, 36 in the TDF-FTC arm. So there was a 44% relative reduction in the incidence of HIV with TDF-FTC. And that was actually the first time we could show that the pill could prevent HIV acquisition. Of course, the level of effectiveness was not as high as expected, but that was the first demonstration. And the explanation for this quite low effectiveness was probably related to the low adherence to daily PrEP in that study, since when the investigator looked at tenofovir level in plasma, only half of the participants had drug detectable. And if everyone had been adherent to tenofovir FTC, 100% should have had tenofovir detected in their plasma. And 5 years later, 2 European studies conducted also among MSM and transgender women, one in the UK, the other one in France and Canada, demonstrated at the same time the high effectiveness of PrEP when adherence is higher. The first was the PROUD study in the UK, where MSM were randomized to receive PrEP immediately with TDF-FTC or after 12 months. And you could see that the incidence of HIV in blue with immediate PrEP was 1.2% as compared to 9% in the deferred arm. So the effectiveness was 86%, quite high. At the same time, we presented the results of the on-demand PrEP trial with TDF-FTC, the IPERGAY study, conducted in France and Canada with the 2-1-1 dosing regimen, which allows you to actually know how to start and stop PrEP in people who have a single sexual intercourse. Shown on this slide, 4 pills to cover 1 sexual intercourse. And in that study, we end up with a similar effectiveness of 86%. And you can see that in blue, the incidence of HIV infection in the active arm, in the PrEP arm, was less than 1%. Whereas it was 6.6% in red in the placebo arm. So again, a very strong effectiveness of TDF-FTC. And these were intent to treat analysis results. When you look at on-treatment results, there were no infections in the TDF-FTC arm. In addition, following the double-blind phase of the study, there was an open-label phase until approval of TDF-FTC in France. And during this open-label phase of nearly 18 months, you could see that the incidence of HIV infection with TDF-FTC was even lower, 0.19%. So clearly with PrEP, once people know it is an effective tool to prevent HIV acquisition, there is a high adherence and therefore a low HIV incidence. And in that trial, the relative reduction of incidence of HIV versus placebo was 97%. So again, PrEP is very effective as long as it is taken as recommended. We confirmed these data in an ongoing cohort study, the Prevenir study with the INRS in France, where actually high-risk adults, HIV negative with inconsistent condom use, could be enrolled and could choose whether they want to start daily or on-demand TDF-FTC. And this trial recruited more than 3,000 people. And we presented in Mexico last year that the global HIV incidence in the cohort was less than 0.1%, which is very low, and again confirms the high effectiveness of both daily and on-demand PrEP. And that's why actually during the same conference, WHO endorsed the 2-1-1 on-demand PrEP regimen with TDF-FTC for gay men and transgender women. And this is also implemented now in European and IAS USA guidelines. And a number of countries and even cities in the US are recommending for gay men either daily or on-demand PrEP. Another interesting data was published recently by Ken Meyer and colleagues in what's called the Discover trial, where again, nearly 5,000 MSM were randomized to receive either daily TDF-FTC or daily FTAF, a combination which is used for the treatment of HIV infection. And if we look at the 96-week results, you can see that the incidence of HIV infection with FTAF was 0.16% versus 0.3% with FTDF. And if you look at the incidence rate ratio, it was below 1, favoring FTAF. And you could see that the upper bound of the confidence interval actually doesn't cross the non-inferiority margin. So you could claim that FTAF is non-inferior to TDF-FTC, but it was not superior because the threshold of 1 was crossed in the confidence interval. So it's as good as TDF, non-inferior, but not superior. And it is an interesting option for people not able to use TDF-FTC because of renal failure or because of osteoporosis or osteopenia. Another important issue when providing PrEP is the selection of resistant mutation in people with breakthrough HIV infection on PrEP. So what are the data? And this slide summarizes data from a number of clinical trials. And I think there are 2 main situations. In the middle row here, if you start PrEP in someone with undiagnosed acute infection, And this is usually seen at enrollment in PrEP trials. Obviously, if you start TDF-FTC in someone with HIV infection, you are bound to see a high rate of resistance. And in this case, 48% of people had developed resistance, mainly the M184V or R mutation, and in one instance also the K65R mutation. So this is expected, and that's why it's so critical to roll out acute HIV infection before starting PrEP. On the other hand, if you look at the rate of resistance in people who seroconvert after enrollment, then the main reason for developing HIV infection is because these people are not adherent to PrEP, and therefore there is a high likelihood of being infected with a wild-type virus. And that's why, in this case, the rate of resistance is very low, less than 3%. Nevertheless, there have been a couple of reports in people highly adherent to PrEP, where when they actually were diagnosed with HIV infection, a number of mutations were actually detected in the genotype. But if we look more closely at some of these cases, we actually realized that the first case here, reported by Marty Markowitz, was actually diagnosed at the first visit after PrEP initiation in a patient actually who deferred PrEP after the first visit. So we're not sure that these people was not acutely infected at the time he really started PrEP. The second case was diagnosed 13 months after the first PrEP visit, or the PrEP initiation visit, but that was actually his first post-initiation visit because this participant had missed a previous visit. And actually he was off PrEP for a couple of months before starting and before being diagnosed with HIV. So again, it's unsure whether these mutations are related to the selection due to PrEP, or the infection with a virus that might be already resistant to PrEP in this individual. And the last case was also an individual with a single mutation M184V at the time of diagnosis of HIV, 8 weeks after PrEP initiation, in someone who had at baseline only a negative third generation assay, not a fourth generation. So we don't know whether this individual had acute HIV infection, and we know that third generation assay can miss actually acutely HIV infection. So as long as we don't have a plasma viral load at baseline, we're not sure that actually this individual was not already infected. Nevertheless, let's look now at the impact of this mutation M184V on the PrEP effectiveness. And to really look at this issue, we need to rely on macaque models. And this is a study conducted by the CDC, by Kong and colleagues in the US, where they assess in their macaque model whether a SHIV virus with the M184V mutation could be used to demonstrate the efficacy of PrEP with TDF-FTC. So in the control animals, following rectal challenges with the SHIV virus, all animals became infected after a couple of challenges. In those receiving PrEP with TDF-FTC before and after exposure, they were all protected. So clearly in this model, the M184V mutation does not reduce the effectiveness of PrEP, and potentially because this mutation induces an hypersusceptibility of the virus to TDF. This is quite different with the K65R mutation. In that case, the efficacy of PrEP is quite significantly diminished to only 33%. But if we look at the prevalence of this mutation K65R in treatment-naive patients to see how many of them are infected with a virus containing this mutation, you could see that overall, this is a rare mutation, less than 0.1%. So of treatment-naive patients are infected with these mutations. So again, the likelihood of being exposed to a virus with the K65R mutation, which may actually reduce the efficacy of PrEP, is very rare. It's about 1 in 1,000 cases. What about cabotegravir? Now, I mentioned that at IAS earlier this year, Rafi Landowitz and colleagues presented for the first time data demonstrating the efficacy of cabotegravir long-acting among men and transgender women. And in that study, a very large study, again, multinational study with patients enrolled also in Asia, patients were randomized to receive in a double-blind, placebo-controlled study, either a daily pill of TDF-FTC or injectable cabotegravir every 8 weeks. And the study was prematurely discontinued by the DSMB because of these results showing the efficacy of cabotegravir with an incidence of HIV infection of 0.4% as compared to 1.2% with TDF-FTC. And when you look at the hazard ratio, you can see that it was 0.3%, favoring cabotegravir. And cabotegravir was not only non-inferior, but also superior to TDF-FTC because, as you can see, the one threshold was not crossed. With this study, though, there are a couple of issues and they are resolved yet, and we will learn more in following conferences. Again, it's interesting to see that the incidence of HIV infection in the TDF-FTC arm was quite high, 1.2% higher than in a similar study. And this might be due to the fact that people were receiving a double-blind, double placebo regimen, and maybe adherence to TDF-FTC was not optimal here because people knew they were receiving injection at the same time and they felt that they were receiving active injectable agents and maybe placebo pills. Another issue is the fact that a couple of individuals in the cabotegravir arm also became infected with HIV during the course of the study, and especially these 5 individuals in the red box who, despite receiving injections of cabotegravir at the right time, acquired HIV infection. So we don't know whether this is a PK issue in these individuals or whether these individuals were infected with already resistant strain. And a clearly important issue would be to know whether these people did not develop strains of HIV with resistant mutation to integrase inhibitors. And this is a concern because, again, the CDC group, and here is a study conducted by Razio and collaborators, demonstrated that in the macaque model, when they infected macaque with the Shiv virus and then injected this macaque before seroconversion with cabotegravir, and you can see the cabotegravir concentration in pink and the viral load here in blue, they were able to show that with a single injection of cabotegravir, there was in the dark circles here, resistant mutations to integrase, and in particular in 3 out of 6 macaques, and integrase mutations that would confer not only high-level resistance to cabotegravir, but also cross-resistance to all the other integrase inhibitors. So that's a reminder, again, that before starting any PrEP regimen, whether it's a pill or long-acting cabotegravir, you need to make sure that your individual is not already infected with HIV, so it's critical to exclude acute HIV infection. So in summary, clearly PrEP implementation should be upscaled everywhere in the world, in particular in Asia, and in particular in key populations such as MSM and transgender women. And these populations should have access to PrEP to be protected against HIV acquisition. PrEP with oral TDF-FTC is already very effective when taken as recommended, whether it's daily or on demand. And the number of new options is currently expanding. We presented data on cabotegravir long-acting, for example. Clearly, it's critical to rule out acute HIV infection before starting PrEP. There might be biomedical failures, so breakthrough HIV infection despite the use of PrEP, but these biomedical failures are very rare, and they need to be clearly fully investigated to make sure this is indeed PrEP failures and not adherent failure in those individuals. With that, I'd like to close thanking my collaborators in Paris, all the sponsors and funders over the years, and you for your attention to this presentation.
Thank you very much, Professor Molina, for that very informative talk. And I'm sure that we will have questions and more discussions at the end of this session. Now, let's welcome our second speakers, Dr. Iskandar Azwa. Dr. Azwa is an associate professor of infectious diseases at the University of Malaya. He is currently the clinical lead for the HIV service in the infectious diseases unit. And his research interests include PrEP implementation research among key populations, HPV infection and anal cancer, and evaluation of newer HIV treatment strategies. Much of Dr. Azwa's recent work has focused on increasing community access to HIV prevention biomedical interventions and implementation of CBO-based model for service delivery of HIV care and prevention. He is the chair of the National HIV PrEP Working Group and is also the PI of a pilot PrEP demonstration project in high-risk MSM in Kuala Lumpur, the first demonstration project of PrEP in Malaysia. His talk is the implementation of PrEP, social aspects, and STI risk compensation.
Good afternoon. I'm going to be talking about pre-exposure prophylaxis, sexually transmitted infections, and respiratory compensation from a regional perspective in Southeast Asia today. I've got no conflicts of interest to declare. The outline of my talk is such. I'm going to introduce the topic of risk compensation, then subsequently talk about the evidence of risk compensation, why it matters, PrEP and sexually transmitted infections, some local data in terms of risk behavior, and sexually transmitted infection data from a PrEP demonstration project in Kuala Lumpur, and recommendations on how to move forward. So the benefits of oral Truvada-based PrEP to date have been very clear in preventing sexually transmitted HIV by more than 99% across a wide range of key populations, including MSM, transgender, heterosexuals, and injecting drug users. What we also have started to see more recently is the positive impact of PrEP on HIV incidence at city level, in reducing HIV incidence across a number of cities, including London, San Francisco, and the state of New South Wales. Now, this has been attributed to frequent HIV testing, earlier initiation of antiretroviral therapy, but also PrEP has had to play a significant part in reducing HIV incidence. So what is risk compensation? So risk compensation is defined as an increase in risk-related behaviors when an intervention increases the perception of risk and thereby increasing the sense of protection amongst individuals or a population. Now, risk compensation in the context of PrEP is such that individuals, when they are on an intervention, or in this case PrEP, might reduce their condom use or increase the number of partners or both, increasing their risk of other STIs. From a public health perspective, STIs are the best objective measure of risk compensation, but the most feared in terms of by policymakers, consequence of risk compensation. But this is not the first time we've been here. We've been here before around discussions of risk compensation with the oral contraceptive pill, antiretroviral treatment, post-exposure prophylaxis, and more recently, HPV vaccination. So why does risk compensation matter? Well, risk compensation matters because it might influence ways that prescribers prescribe. So there could be provider concerns around sexual risk compensation associated with reduced willingness to prescribe PrEP. It may reduce potential PrEP users from coming forward to seeking and starting PrEP and continue to sustaining PrEP for fears of stigmatization associated with PrEP and perceived sexual risk-taking. The concerns that PrEP might be less effective in individuals with STIs, although there's no evidence of this to date, and concerns around the increase in antibiotic-resistant sexually transmitted infections. And more importantly, less is known, very little is known about the effect of community-level risk compensation, how PrEP affects sexual behaviors among non-PrEP users in the wider scale-up of PrEP availability. This is some data from the region. This was qualitative data from 19 MSM who were invited to participate in focus group discussions on the acceptability and willingness to use PrEP among MSM in Malaysia. And this relates to essentially questions around risk perception and how risk perception influence condom use behavior. Interestingly, and this was before the introduction of PrEP in Malaysia, most of the participants had low risk perception according to their frequency of condom use and the fact that they were in a monogamous relationship. They perceived this to be sufficient. Participants often viewed PrEP as an additional layer of protection rather than as a replacement for condoms. And condoms were often preferred because it represented a physical barrier that they could see and feel. With respect to PrEP-related stigma, most perceived PrEP in a positive light as seeing users as taking responsibility of their own and partner sexual health. However, there were concerns that others, in particular other MSM, might perceive them negatively as promiscuous or using PrEP as a desire to engage in condomless sex or even chemsex. But rates of STIs predated the introduction of PrEP, and this is nicely shown here in the number of new diagnoses of HIV, syphilis, gonorrhea, and chlamydia from 1996 to 2015 in MSM in England. And what you can see by the green and red lines in particular, denoting the significant rise in gonorrhea and rise in early syphilis infections before the release of the UK-based PROUD study results. So do STIs reduce the efficacy of PrEP? And there's no evidence that STIs lower the evidence of PrEP, both in randomized controls studies and open label studies to date. When we talk about risk compensation, we do need to take into account how we measure STI prevalence and STI incidence in PrEP programs. And some of the limitations have been that many studies lack STI pre-incidence data. PrEP studies also are biased towards selecting persons who are more likely to engage in condomless sex. And the increased screening in PrEP programs, particular in, as recommended by guidelines, by screening every 3 months or so, introduces a detection bias. You're more likely to increase STIs because you're screening more. We know that STIs were increasing prior to the introduction of PrEP on a background of reducing condom use. Risk compensation in the earlier PrEP efficacy trials did not show any evidence of risk compensations, as shown in the graphs above, as denoted by no change in the mean or median number of partners, rates of condomless sex, or incident STIs. However, randomized controlled trials may not provide realistic evidence into risk compensation because participants' perception of protection are unknown, and participants are unaware whether they're receiving an active agent or placebo. One of the first meta-analyses to look at the effect of PrEP on risk compensation was described here, looking at 16 observational and 1 open label studies from 2014 to 2017. This looked at the effect of PrEP on STI diagnosis among MSM and was more likely to provide more real-world data as they involved more demonstration projects than randomized controlled trials. Looking at the forest plots on the left-hand side, we find that the overall pooled odds ratio for any STI diagnoses was 1.24. So starting PrEP resulted in a 24% increase in STI diagnosis. This trended towards significance. Interestingly, there was a significant risk in rectal STIs, and in particular, rectal chlamydia, indicating that more MSM were having unprotected receptive anal sex after the introduction of PrEP. The increase in STI rates were also more in recent studies, reflecting an increasing trust in the HIV protective effect of PrEP and normalization of PrEP for HIV prevention over time. Some specific PrEP demonstration projects are worth mentioning. This includes the Amsterdam PrEP project, which included 365 MSM, where participants were given the option of choosing daily versus event-driven PrEP. 27 chose event-driven PrEP. There was no change in STI incidence over a 2-year follow-up, and there was lower STI incidence among event-driven PrEP users, and this is likely due to lower risk behaviors within this group. There was, however, an increase in number of condomless anal X with casual partners. Within the region, the Thailand Princess PrEP stands out amongst other PrEP demonstration projects, including 1,467 MSM and 230 transgender women. Here, there was no change in condomless sex over 12 months, and there was in fact a decrease in syphilis incidence from 7 to 3%. In terms of STI incidence, only syphilis was described. There was no chlamydia and gonorrhea data. More close to home was the Victoria PrEP-X study, which reported an overall STI incidence of about 91.9 per 100 person years, and showed that STIs were likely to be concentrated in a smaller portion of patients, participants in the study. 13% were diagnosed with more than 3 STIs, accounting for 53% of the overall STI diagnosis. Number of partners predicted STIs and not condom use, and this has been shown elsewhere. STI incidence did increase over a 1-year period of follow-up, even after it was adjusted for the testing frequency. So 21% increase in STIs, particularly in those groups that started PrEP for the first time, as opposed to those already established on PrEP. More recently was a systematic review and meta-analysis of PrEP studies on STI prevalence and incidence, which included also unpublished data from PrEP implementers across the region. 88 studies, most were in MSM, and only 30% were from low and middle income settings. Here they were able to show the pooled prevalence of any composite outcome of chlamydia, gonorrhea, or early syphilis was 23.9%, and the prevalence of gonorrhea or chlamydia by anatomical site was highest in the anal rectum. Looking at pooled incidence, here the pooled incidence of any composite outcome of chlamydia, gonorrhea, syphilis was 72.2 per 100 person years. This included a sample size of 6,300 patients in 11 studies. Once again, the incidence was of chlamydia and gonorrhea was highest in the anal rectum, and reinforces the need for ongoing STI testing and treatment, as PrEP users remain at risk of STIs. Now, looking at the various STI service models in PrEP programs, what we find is that within the region, very little STI screening is being conducted other than for syphilis. So this has been shown in Japan, Brazil, Thailand, and Malaysia. So syphilis predominated your STI screening with very little chlamydia and gonorrhea screening due to costs. This is also to remind us that hepatitis C, which has been well described as an STI in outbreaks of HIV positive men who have sex with men across the US, Europe, and Australia, is beginning to emerge in Asian countries. And this is describing an outbreak of acute hepatitis C infection in a cohort of 563 of HIV positive MSM with acute HIV infection, with significant increase in hepatitis C incidence of 44.8 per 100 person years in 2018. This was largely driven by group sex, methamphetamine use, and syphilis, as shown in the chart on the right. Now, this is data of risk perception and condom use in a local PrEP pilot demonstration project in MSM in Kuala Lumpur, which looked at 150 high-risk MSM. Essentially, it showed that at the beginning of the project, 50.6% believed PrEP to be effective on a background of continuing to believe that condoms were essential to continue to be used. What we found in terms of sexual risk behavior over time in the demonstration project was that there was an initial increase in the number of partners at 3 months, and then peaked at 6 months, and this was followed by a decrease and then leveling off of sexual partners up to 12 months. This was described as a honeymoon effect, with an increase in sexual partners initially and then subsequently leveling over time. Looking at the graph on the right, we find that the level of condom use, as denoted by never condom use, increased over time. Similarly, the number of participants reporting always condom use decreased over time. Interestingly, the rates of condomless sex did not change significantly at any time point. Looking specifically at STIs, high rates, extremely high rates of STIs at baseline. So any STI, up to 1 in 2 participants had any STI. This was particularly prevalent in chlamydia, and this is actually anal chlamydia and syphilis as well. So these are sites denoted. So participants were screened every 6 months at baseline, 6 and 12 months. for syphilis, rectal chlamydia, and rectal gonorrhea. So very high rates predating the introduction of PrEP. This shows the cumulative STIs diagnosed per participant during the study, and essentially what was mentioned before, that a significant proportion of participants, a significant proportion of STIs were concentrated really in a minority of patients with repeat STIs. Some of the lessons learned and recommendations from the MyPrEP demonstration project, specifically around risk compensation and STIs, showed that there was an opportunity for STI control and prevention. There was high prevalence of baseline STIs, which preceded the initiation of PrEP, most of which were asymptomatic, reinforcing that we were reaching the group that were at higher risk of HIV and STIs, and emphasizing the importance of regular screening and treatment of extragenital STIs and syphilis within the MSM population. Screening of extragenital STIs in MSM is imperative and should include lower middle income countries due to the high burden of asymptomatic rectal, chlamydia, and gonorrhea infections within this group, which otherwise would have been missed. And that self-sampling for rectal STIs was acceptable to these patients. Messaging of safer sex in the era of PrEP needs to change to reduce stigma. It's likely that with perceived HIV protection offered by PrEP, rates of condomless sex are likely to increase over time. The messaging of safer sex in the era of PrEP needs to evolve in such a way that patients are not shamed or stigmatized by healthcare professionals for not using condoms if they feel they're adequately protected from HIV. PrEP use needs to be reframed as a positive and responsible option to remain HIV negative, and that potential PrEP users are seen as taking control over their sexual health. We've shown that STI screening efforts should be prioritized amongst that select group of patients who are engaging in chemsex and those with repeat STIs. There were high levels of uses of substance in the sexualized context within this demonstration project, up to 40%, mainly using chemsex. And despite this, chemsex did not appear to impact on overall PrEP adherence. Chemsex was also a significant predictor of STI positivity during the study with an adjusted hazards ratio of 1.46. So what can we do about it? Essentially, we need to move beyond the syndromic approach of STI management, largely which is hindered by the cost of STIs and the misplaced belief that symptomatic STIs are more important. PrEP programs must be combined with regular STI screening, and one way of doing this is to make sure it's included in national PrEP and STI guidelines. Include chlamydia and gonorrhea NATs as part of screening. And one way of reducing the cost of this is to look at pooled NAT sampling from the 3 different sites, the pharynx, the urine, and the rectum, versus separate 3-site screening can be cost saving and is feasible. We've shown self-sampling is feasible as well. And continued negotiation through regional bulk pricing to try and lower the cost of NATs. And further research into accurate and affordable point-of-care diagnostics for chlamydia and gonorrhea. Increased frequency of screening. Models have shown that increased screening among PrEP users may lead to overall decrease in level of STI incidence. Integrate services into existing services, so HIV testing or services or sexual and reproductive healthcare services. Build capacity for CBOs and key population-led services to screen and treat STIs, and community engagement and advocacy to generate demand like everything else we do in HIV. Evaluate novel STI innovations, and this is looking at doxycycline prophylaxis for STIs, which has been shown in the IPERGAY study to reduce the incidence of chlamydia and syphilis, but not gonorrhea, unsurprisingly. And this has now moved forward into further doxycycline PEP and PrEP studies in MSM in US, Australia, and France, and also in Kenyan women. Currently, the recommendation, however, is antibiotic prophylaxis for STIs is not currently recommended pending further clinical studies. And vaccinate. Now, HPV vaccination is underutilized within the region, both for women and men. Here we were able to demonstrate high rates of anal HPV infection in the anal region in this cohort of HIV negative and HIV positive MSM in Indonesia, Thailand, and Malaysia, up to about 70% of high-risk HPV infection, with the most common being HPV 16. And this represents essentially a lost opportunity for reducing the burden and incidence of HPV infection within MSM. But above else, we need to talk about chemsex and how it is driving the HIV epidemic, not just across the region, but globally. Recent data has shown crystal meth to be a major risk factor for HIV seroconversions among MSM. And we have described some data locally, and there has been more movement within the region trying to define the problem and talk about the problem and devising evidence-based interventions to introduce interventions around addressing chemsex. But above all, let's not forget about the benefits that PrEP has provided to the thousands of users who have started on PrEP. PrEP users report fringe benefits, including feeling safer during sex, less anxiety, and stronger relationships. PrEP empowers users by allowing greater control of their HIV risk, rather than relying on partners to use condoms, take part, or accurately disclose their HIV status. There's strong evidence that PrEP results in improved mental health among PrEP users. PrEP has revolutionized the way in which HIV serodiscordant couples conceive, as it provides an additional layer of protection in the HIV negative partner in those desiring pregnancy. PrEP also addresses the unarticulated concerns around reduced sensation associated with condom use, interference with erectile dysfunction, and disruption of spontaneity associated with condoms. PrEP has the potential to reduce HIV stigma by facilitating greater interaction between HIV negative and HIV positive people. In conclusion, high STI rates predated the introduction of PrEP. There's been evidence of a small increase in STI rates after PrEP use. Criticism on PrEP causing increase in STIs is not helpful, unsound, and overly simplistic. PrEP is an opportunity for increased attention to STI prevention and control. Clinicians and policymakers should not impede PrEP access out of concerns for risk compensation, as this is unlikely to undermine the effectiveness of PrEP in preventing HIV prevention. PrEP use needs to be reframed as a positive and responsible option to remain HIV negative. With that, I'd like to acknowledge the various funders on this slide, as well as the many collaborators on the slides and those who allowed me to pinch their slides. Thank you very much.
Thank you very much, Dr. Azwa, for that very interesting aspect of PrEP implementation. And now our last but not least speaker, Dr. Stephane Wen-Wei. Dr. Koo is currently Director of Division of Infectious Diseases at Taipei City Hospital, Renai branch, and clinical researcher with Treat Asia Network at Taipei Veterans General Hospital. Dr. Koo's research interests include HIV/AIDS, STDs, chemsex, and sexual well-being of LGBT community. And he has been most actively involved in PrEP implementation in Taiwan. The title of his talk is PrEP Implementation in Real Life, Case-Based Presentation.
Hello, everyone. I'd like to thank the organizer for inviting me and give me a chance to share our experience in implementing PrEP in real life. So in the following couple of minutes, we're going to present 4 different cases addressing different issues from different key populations. So let's start with case 1. This is Mr. A. He's a 32-year-old single man who has sex with men. He's sales manager and came to our clinic for post-exposure prophylaxis. It's because he had an unprotected insertive anal intercourse at the sauna yesterday. So actually, he didn't come to the clinic for the first time. He had the PrEP service, second time this year. Also, he had used post-exposure prophylaxis several times in other hospitals in the last couple of years. He said he didn't have any history of sexually transmitted infections before, and he had hepatitis B vaccination at childhood. So this is pretty common cases in the PrEP clinic that he has been used PEP for many times, but he didn't start PrEP yet. So you probably are wondering why he had this choice. So he said he had a regular HIV test almost every 3 months. And actually, the last time he had the HIV test, and it was negative when he completed the previous PrEP episode. And he actually used condom regularly, but he said that sometimes he will not use condom if the partner asks for barebacking or colorless anal intercourse at the sauna. So he wouldn't wear it. And after that, he regretted. So he actually heard about PrEP before, but he said he didn't want to take pills every day. So also he said like he didn't have sex that often, so he probably once weekly, so he didn't want to use PrEP daily. Although he does know that some drugs like PrEP can prevent HIV. So we did some baseline checkup for him before starting post-exposure prophylaxis. So he's negative for HIV, syphilis. Also, he doesn't have hepatitis B or hepatitis C. His liver and kidney functions are all normal. So what would you suggest him? Would you suggest him to keep PrEP? And after PrEP, would you suggest him to start PrEP immediately? So this is a very common scenario in our PrEP clinic. The client came first because they asked for PrEP, and then they realized that they should keep PrEP after completion of PrEP. This is the WHO PrEP implementation tool. So as you can see that if people remain at risk for HIV infection and their tests were negative for HIV, they should continue PrEP right after PrEP without any gap. And it's in different countries, there were different PrEP regimens. For example, in Taiwan, we will use CDF-ATC plus dolutegravir or retiregravir. So the PrEP regimen pretty depends on different countries' recommendation. And for this client, initially he didn't want to use PrEP. It's because he didn't have frequent sex and he doesn't want to take medication daily. So according to the hypergate study and Prevenir studies, we have very solid evidence showing that for MSM, it's equally effective to use event-driven PrEP or ED PrEP to prevent HIV, same as daily PrEP. So it's quite important and also very nice to ask our client what kind of preference they have and what kind of lifestyle they have. So if our clients if they can plan sex, and if they didn't have frequent sex, for example, they have less than 2 sex per week, and they understand, can remember the event-driven PrEP regimen correctly. And most importantly, if they're HBV negative, they don't have hepatitis B, then they might be eligible to use on-demand PrEP or event-driven PrEP. It's not uncommon that people switch from one regimen to another. So it's pretty depends on the lifestyle and also the current rates of our client. So it's quite nice that we ask them about their prevalence each time when they visit the clinic. So let's jump to case 2. This is Mr. B. He's a 25-year-old single gay man. He works as a trainer in the gym, and he came to the clinic for PrEP. He stated that he actually had unprotected inserted anal sex last weekend. And we keep asking other possible risk factors. He said that he actually used ice or crystal methamphetamine during sex almost weekly. So he actually practiced chemsex weekly. He also had a history of gonococcal urethritis a year ago. He never used post-exposure prophylaxis before, and he had hepatitis B vaccination at childhood. So we would like to know his risks and why he wanted to use PrEP. So he said that he actually had regular HIV testing as well. He usually used saliva-based HIV self-test, and he had that 2 months ago and it was negative. His previous recent sexual behavior, he said he had continuous anal sex last weekend, and actually 2 weeks ago, he also had another episode, and it's usually during chemsex. And he had he started to have chemsex or high fun a year ago, and just recently he started to do slamming or injected use of crystal meth. So because of chemsex, he usually don't wear he usually doesn't wear condom because it's not comfortable. So it seemed like it's a very suitable case to start PrEP because he actually have quite high risk for HIV infection. He had previous STIs, and also he had chemsex, and he also have frequent colorless anal sex. So we asked him about acute HIV syndromes, and he said he doesn't have fever, sore throat, headache, rash, or diarrhea at that moment. So what would you do first? Would you just prescribe PrEP immediately, or would you like to do some more tests? So, so it's quite important that we have to make sure that our client is negative for HIV before we start PrEP. So in this case, for Mr. B, he actually had quite risky sexual encounters or possible exposures to HIV a week or even 2 weeks ago. So we really have to be cautious and make sure that he doesn't have HIV right now. So we actually ordered sensitive HIV test, which is a 4th generation HIV rapid test. So as you can see in the slide, we actually use 2 different HIV assays for him. The above one is a 3rd generation HIV rapid test, which tests for anti-HIV antibody only. And the below one is a 4th generation HIV rapid test, which tests both antibody and antigen. So it's a HIV combo test. As you might see, there's a very faint line on the 4th generation stripped at the antigen column. So, but you don't see any other lines in the antibody columns, which indicate that he actually had an acute HIV infection, and he's undergoing a seroconversion process. So of course, he has been diagnosed with acute HIV infection. We didn't start PrEP, rather we started HIV treatment for him. So although most people with acute HIV infection presenting with certain or some acute HIV or acute viral syndromes. For example, like headache, fever, sore throat, rash, mouth sores, or diarrhea. Sometimes it's asymptomatic, like our case. So it's we should always be cautious if our individual prevents certain or high risk for HIV infection, and they reported condomless sex in the past 14 days. And to rule out such possibilities, we can use either fourth generation HIV combo assay, or even choose an NAT test or check the viral load immediately if you have a high suspicion. So we're going to the case 3. So case 3 is Mrs. C. She's a 34-year-old heterosexual woman. She works as an office worker, and she came to our clinic with her boyfriend for post-exposure prophylaxis. So her boyfriend actually lives with HIV. He has been diagnosed with HIV a long time ago and has been on suppressive ART regimen for many years. The reason why they came to the office because they would get married and plan to have children. So both of them has no history of injection drug use, and they have no history of STIs. So we asked Miss C why she would like to our clinic for PrEP. She said she knew that her boyfriend had HIV and they have been together for 3 years, and she actually want to get married with him and continue to have babies, but they don't want to do artificial reproductive technology because it was more expensive. So she had a regular HIV test and it was negative. So usually they use condoms. For contraception, but if they want to have babies, they may stop using condoms, and they might consider using PrEP. So how would you suggest her? Actually, there are more evidence showing that if somebody living with HIV had a suppressive viral load for more than 6 months, they cannot pass the virus to their sexual partners. This is known as U equals U. So there's actually no additional benefit for serodiscordant couples to use PrEP to have extra benefit to prevent HIV infection. However, in several scenarios, PrEP is still considered for some reasons. For example, if the partner with HIV hasn't achieved a sustained viral suppression, or we are not assured about the consistency of the HIV positive partner taking ART, or even for some psychological reasons that the HIV negative partners want to start PrEP, it's actually still recommended if the HIV negative part would choose to take PrEP for HIV prevention. So it's a lot of women would worried about whether using PrEP is safe during pregnancy or breastfeeding. So according to the experience in people living with HIV using TDF or FTC for treatment of HIV, is actually quite safe, and there was no adverse pregnancy outcomes when people are using TDF-FTC as treatment, or in previous studies conducting serodiscordant couples as PrEP. So for women who want to use PrEP during pregnancy and breastfeeding, it is actually safe. Finally, we are going to case 4. This is Mr. D, a 17 years old single gay man. He's an adolescent and studying in high school. He was referred to our clinic by LGBT NGO for post-exposure prophylaxis because he had unprotected receptive anal intercourse with someone from a dating app 1 day ago. He had a PrEP once 1 year ago. He didn't have chemsex, and he also had anal genital warts before. He had HPV vaccination at childhood. So we want to know why he had these encounters. So he said he actually have regular HIV tests. He always used condom, but sometimes when people took their condoms without telling him, he couldn't resist it. And also that when he was with his ex-boyfriend, he didn't use condom because he wanted to trust each other. And when he had this time met somebody on the dating app, he didn't tell him the true age he actually is. And also he used PrEP last time. He couldn't afford it, so he told his parents, and his parents get really angry and almost kick him out of home. So he didn't think that his parents can pay for PrEP this time. Also, so they couldn't accept him as gay. So should he take PrEP? So this is so a lot of this is a quite difficult case for most of the physicians, because for adolescents, it takes so many details to remember and also to work on. For example, a lot of people are worried about whether PrEP can be used safely for adolescents or young adults. This is a WHO implementation tool again, and showing that according to the recent ATN 113 study, it's actually safe to use in adolescent. And also, it has been approved by the US FDA to use adolescents who have a weight at least 35 kilos. However, there are other issues that we should address. For example, the age consent for providing HIV testing, and also we should report any sexual intercourse done by minors. So for different countries, doctors should be aware of these issues and seek for a better solution. For example, in Taiwan, we probably will refer this client to anonymous VCT. So there's a way to protect his anonymous status, and he won't be reported to the officials. And also it takes more support to ensure the adherence of PrEP for adolescents. For example, in previous studies, adolescents tend to stop PrEP early, and they might not come for follow-ups. So for adolescents, it may be prudent to have more frequent contact or follow-ups, and also we might need some experienced counselors who have been working with adolescents or young adults to gain their trust. Also, additional support would be great if we can have, for example, peer support or providing economic incentives for these individuals to come back. And also sometimes we need to deal with the structural barriers such as the gender issues, like in this case that his parents are not accepting him as a gay man. So in short, that we need multidisciplinary support for our adolescent individuals. To summarize, we have demonstrated different issues regarding key populations. For example, for MSM, event-driven dosing is recommended if our clients have no HIV infection or are able to plan sex and have sex infrequently. For serodiscordant couples, HIV-negative women can safely use PrEP during pregnancy and breastfeeding. And also for adolescent and young adults, PrEP is still indicated for at-risk individuals, although returns to care and adherence to medication, other structural barriers mandate more multidisciplinary support. And PrEP can be initiated immediately after completion of post-exposure prophylaxis. And also it's important to notice that acute HIV infection should be bear in mind in individuals who have acute retroviral syndrome and colonless sex in the past 14 days, and we should screen with a more sensitive assay. Thank you very much.
Thank you very much for all these great presentations. And please join me in welcoming Professor Molina, Dr. Azwa, and Dr. Koo into this roundtable discussion. We have heard a lot about the science behind PrEP and the chance of getting drug resistance with the missed acute HIV infection from various speakers today. If I can, I may want to start the question directing to Professor Molina about the screening of acute HIV infection. We know that, there is no way that we can screen out 100% of people who have acute HIV infection. But from your experiences and implementation in various settings, what would you recommend for countries like us in the Asia-Pacific region who may not always have the fourth generation EIA or even nucleic acid testing? What would be your practical tips in screening out acute HIV?
Thank you, Dr. Phanuphak. This is indeed a very important question. I think, if you're not able to test for HIV RNA, which is not always possible, even, in Europe, in those individuals, I think that the best way would be to, double check the HIV serologic assay at the second visit a month after PrEP initiation. So at that time, even if you have missed acute HIV infection, at the time of PrEP initiation, you can at least make an early diagnosis of HIV at a second visit. That's why we encourage, after studying PrEP, to schedule a second visit a month after PrEP initiation. And of course, if you could have a fourth generation assay for the first visit. And again, what we recommend is to have the results of an HIV combined assay for detecting both the p224 antigen and the antibodies within a week before starting PrEP. But if this is difficult to handle, then the best way would be to see the patient again a month later.
Yes, related to that question, and thank you very much, Professor Molina. I also would like to direct this question both to you and to Dr. Koo, related to the use of HIV self-testing. Even either for prior to PrEP initiation or during PrEP follow-up, what has been your experience so far, and what would be your recommendations in using? I would like to include both the oral fluid and the blood-based HIV self-testing.
Thank you, Dr. Nittaya. So for most of the HIV self-tests were third generation. So the best window period that we have is around 2 months. So I personally would not suggest people to do self-test and then start PrEP by themselves, because we have used like a fourth generation rapid test, even by lay people in Taiwan for like HIV lay testing. So it's quite convenient to do the fourth generation here. But if one country would love to start a self-test program, like an implementation program plus PrEP incorporated, I think we have to follow these clients more closely. Another issue would be the risk stratification. For a lot of clients who are having PrEP, they are pretty stable and they tend to follow up regularly. And I think for these clients, we might consider to implement a combined self-testing and clinical-based testing all together, so people don't have to come back to the clinic that often. For example, they can just come back every 6 months, and for every 3 months, they're using a self-testing complemented by fourth generation in the clinic. But for those people who are at higher risk, for example, they're doing chemsex, having STD infection quite frequently, or they are not taking PrEP like regularly, I would really suggest them to come back to clinic and have a fourth generation a test as a regular follow-up.
Wonderful to hear. Professor Molina, would you like to add to that? In particularly with COVID-19, have you experienced the use of like self-testing more among PrEP users during this time?
I would say I would like to echo what Dr. Koo just said, and I think self-testing is really not appropriate for PrEP users, especially those at high risk of being exposed to HIV. So I think, you know, we should have these individuals get the fourth generation assay if they could. In terms of rapid tests, there are some tests that are now being evaluated for detecting also the P24 antigen and the antibodies, and some of them seem to be quite interesting. But I think it's premature yet to recommend these combined rapid tests. And so I would say for the time being, we need to continue to use these tests and to repeat the fourth generation assay if we could. Or, you know, what's critical is to be able to repeat these tests at every time we see these clients in the clinic. That's key. What we want to avoid is someone with HIV infection not knowing about his HIV infection and being able to transmit the virus. And so we want to make sure that we can diagnose HIV infection as early as possible in these people.
Thank you very much. That's a very important point, Professor Molina and Stephane. Now let's turn to Iskandar. You have been talking about risk compensation, and I think the discussions around risk compensation and PrEP will be ongoing for years after now. My question to you is because like most of you here are infectious disease doctors. I'm not. I'm a dermatologist. I just would like to hear from you how you think this discussion around risk compensation is related to PrEP stigma or to stigma around sex rather than the risk compensation related to STI, unplanned pregnancy itself. How you think this is related? This probably will be questions to all of you. And how have you done? What have you done to overcome these discussions or these PrEP stigma things in your own setting?
Thanks, Nittaya, for the question, and always nice to see you. You know, I think one of the concerns and why I was particularly interested in giving this in this talk was, you know, in a conservative country like Malaysia, the issues around sex and talking about sex is particularly a big obstacle around PrEP implementation and scale up. A lot of the focus there, and largely by infectious disease doctors and as well as policymakers, has largely been around the concern around STIs. And also by extension, with the increasing concerns around STIs, the increase in resistant STIs. But it's interesting that when you delve further into the topic, it goes beyond that. And, you know, I don't think it's not unique to this, to Southeast Asian countries or more conservative Muslim countries. This is, I think, probably a big reason why the UK as well took a long time to get NHS England to take over the dispensing and prescribing of PrEP. So I think we always start with the discussion around STIs, because at least you can argue that from a public health approach, at least. The discussion around taking away from the pleasure of sex amongst a population who are choosing a prevention option which protects them from HIV, you know, I mean, I think I think there's certainly that aspect of it. And when you delve further, a lot of the PrEP stigma is around that, around denying people, I guess, or a certain group of people, the pleasure of having intimacy the way they should be allowed to. But that conversation is very hard to have amongst public health officials, amongst your colleagues, infectious disease physicians. And I think when that discussion is had, perhaps we should start with STIs at least. It's an easier discussion to have. And then you can move slowly towards intimacy, sex. That's why, you know, I only had one slide towards the end on that, but it's very, very important. And, you know, I agree, it's extremely important to have that discussion. And that's why it's so important to frame PrEP in that positive sense, in that positive light. That I think the way around that is to you know, as a lot of us who are struggling with trying to implement PrEP, is to frame it as the users, the potential users, are trying to be more proactive about their sexual health, and they're doing something good rather than the other way around.
Great answer. And Professor Molina, Stephane, would you like to join in this question as well?
Well, I would say I agree with what Iskandar just said. Is very right. I think the issue of STI, around STI, should be you know, addressed. And there are different ways to address this issue. One is to explain that, you know, people on PrEP are being seen by their physician more often, and they are being tested for STIs, and that we are diagnosing a lot of asymptomatic STIs. And by, you know, early diagnosis and early treatment of these STI, we can break the, you know, the transmission cycle to their partners. And so we may eventually also improve the care for STIs in these populations. So, you know, if we think also, when we talk about risk compensation is reducing the use of condoms, I think the answer is yes, there is a reduced use of condoms in people on PrEP. And so we need to do potentially more in terms of STI prevention. And it's not only about condoms, it's also in terms of, you know, the number of sexual partners that you have, which is at least as important as the use of condoms. And so what we have seen so far in PrEP clients is that they are using less condoms, but they don't have a, you know, an increase in the number of sexual partners at the same time. So that's all I can say at this point.
I would like to add it, interestingly and also unfortunately, like in Taiwan, we have the increase of gonorrhea and syphilis, and also hepatitis C starting this year. And it's not universal, it's actually universal in MSM and also heterosexual individuals. So it has nothing to do with PrEP directly, because PrEP are mostly used by MSM here. So while we'll see there might be a stigma, we also see how little resources that the government have or the public department have put on STIs, because usually they are more cared about HIV, and now we realize that a lot of doctors don't know how to treat STI properly, and also we don't, our national health insurance wasn't reimbursing NAT properly, or we don't screen asymptomatic patients. So whenever there's obstacles or barriers or stigma, I think this is also a good chance to make some change to the healthcare systems.
So, if I could just maybe have 1 minute say to this.
Yes, sure.
Is that especially in the Asian setting, and I highlighted it as well earlier on, there's very little STI screening going on in Asia apart from syphilis. So it reinforces, we need to look at chlamydia and gonorrhea. It's the right time to do it. Pooled STI testing is the way forward. We're beginning to demonstrate extremely high rates of rectal infections. And if we don't use this opportunity, I don't know when we will ever use this opportunity to screen for STIs.
Mm-hmm. That's a wonderful summary of everything. Actually, Iskandar, thank you very much for making that statement. And we should use PrEP to now turn from a weak STI infrastructure in our region into a much stronger STI infrastructure in the near future. So it's coming to the end of the discussion. Sorry that we have so little time to discuss with all of you, but I believe that all the audience today have learned so much from you. And we thank you and thank all the audience for joining us in this session. Please stay tuned, everyone. We will have the Meet the Expert session after this, after Professor Kiat make his closing remarks. Thank you very much.
Thank you.
Thank you.
Okay, I'd like to thank all the speakers for the wonderful second session that we just finished. I have been learning a lot, and I believe that all the audience also enjoy all the discussion and the talk. And also would like to thank the chair, both the chair of the first session, Professor Phanuphak, and the second chair, also another Dr. Phanuphak, Nittaya, and all these great speakers. I think we really learned a lot. What we're going to have is I'd like to thank the VIP Healthcare for supporting these very useful programs, and I'd like to also inform all the audience that if you provide us the surveys, feedback, and then the certificate of attendance will be made available for you. Please join us again. The talk, all the material that have for these two sessions, including tomorrow another two sessions, all the slide presentation will be made available very shortly. And please remember that we going to have the other two more very interesting sessions tomorrow, day 2 of the programs. The session 3, and you see the subtypes, the gender, ethnicity, whether impact HIV care. And the last session will be clinical management in the near future. So all the great speaker lineup for you to enjoy the presentation and sharing their experiences. And today's also remember that Meet the Expert for the first session will be starting soon, and also the for the second session as well. For tomorrow, please sign up if you want to also meet the speaker for the tomorrow session. And all the online way that you can connect to this program, the virology education. Okay, thank you very much, all the chairs and the speaker, particularly all the audience that stay tuned until now. Thank you very much. Bye now.